Good morning. I am Asmaa Nabil, resident in Ain Shams University. Today, I will have this presentation with my colleague Hend Gamal. Presenter view. So presenter view, we would like to acknowledge with deep appreciation and gratitude the invaluable help of Dr. Karim Abdel Tawab and Dr. Rana Tariq for allowing us to share their exceptional work. So when we talk about IR and women's health, this is our presentation today. The first thing to come in mind is uterine fibroid embolization. However, the reality is that we have way more procedures and interventions that could help in women's health than uterine fibroid embolization. In this presentation, we will try to focus on few other procedures.
So, IR play a very important role in women's health with growing role, especially in vaginal bleeding. We have also pelvic congestion syndrome management, as well as many other interventions like tubal coiling, drainage of pelvic abscesses, and breast interventions. So, gynecological and obstetric hemorrhage is a significant cause of female morbidity and mortality throughout the world. Postpartum hemorrhage itself accounts for 25% of maternal death worldwide. Interventional radiology now play a very important role in the prophylaxis and management of these cases. So our first case, we have a 31-year-old female patient admitted to the OB/GYN department at Shams University Hospitals and referred to our unit with severe postpartum hemorrhage. The patient was shocked with a vital data, blood pressure 80/40, pulse 120 beats per minute, and hemoglobin drop 4 grams per deciliter. So immediate consultation of the IR staff was done, rapid decision was taken, and immediately the patient was prepared for intervention. So here we can see characterization of the left uterine artery. The left uterine artery angiogram revealed markedly tortuous dilated vessel denoting atony. To the left, we can see the control angiogram after gel foam with no contrast filling. So here is the right uterine artery characterization. On the right side, there was another cause of vaginal bleeding, with, as we can see, an indirect sign of bleeding, which is the dilated or ectatic C-shaped distal uterine artery branch. And to the left, we can see the control angiogram after gel foam impulization. Characterization of a cervical branch was done and revealed marked contrast extravasation. Impulization by gel foam also was done, and the control image showed no contrast extravasation. In this case, we need to highlight that we need to castratrize all the branch that may represent source of bleeding to fully control the source of bleeding. So what is the difference between impulization and surgical ligation? Impulization produces a hemostatic mechanism at a distal level, which is more efficient than surgical ligation that is done at more proximal level. And gel foam is used for its temporary effect of hemostasis. Its main aim is to produce a hemostatic mechanism. So here we can see a brief about the hemostatic algorithm used for postpartum hemorrhage. We can use the word stasis, starting with shift to theater, then moving to tamponading, apply compression suture, P-lunch or modified. We have surgical pelvic devascularization, uterine or internal iliac artery ligation, then moving to our rule, which is uterine artery impulization, which is just before the subtotal or total abdominal hysterectomy. Here is the recent published series describes the effectiveness of uterine artery in cessation of postpartum hemorrhage and its role in limiting the need of hysterectomy. Now moving to my colleague Asmaa in the second case.
Our second case, a young lady that underwent DNC presented to our IR unit with persistent massive vaginal bleeding. She was a little bit hypotensive, little bit tachycardic, with hemoglobin level 7 grams per deciliter. So transvaginal ultrasound was done, and it showed multiple uterine abnormal vessels with high peak systolic velocity, low resistance, that denote many direct arteriovenous connections. So angiogram was done. After catheterization of the left uterine artery, angiography showed filling of cervicovaginal branch, unfortunately not shown in this particular image. Coiling of this branch was done. to avoid non-target embolization to the vaginal artery to avoid ischemic vaginitis. Here we can see felling of abnormal vessels supplied by the left uterine artery with early venous felling. This denotes an AV malformation. Embolization of the left uterine artery was done by hysteroacrylipidol mixture 1 to 3. Control angiogram show no felling of those AVM vessels with preservation of other internal iliac artery branches. Characterization of the right uterine artery shows another large dominant feeder of the abnormal vascular malformation. Embolization with hysteroacrylipidol mixture was done, and to the left we can see that control angiogram with complete non-contrast opacification of those vascular channels and glucose shown in non-subtracted image. In this previous case, we can highlight 2 points. In vaginal bleeding, patients with surgical history of cesarean section, induced abortion, DNC, we should suspect an iatrogenic AV malformation. Also, in patients with vaginal bleeding, if they are stable and few episodes of bleeding, we should undergo medical treatment first. And if it's not working, we can proceed for uterine artery embolization. The third case we have today is a case with placenta previa with anticipated massive bleeding during delivery. So the patient was presented to our IR unit just before cesarean section. Those are the types of placenta previa. In this case, we can do bilateral common iliac artery or bilateral internal iliac artery balloon occlusion. This is the ultrasound was done to them. It shows homogeneous placenta with clear interface between the uterine serosa and the urinary bladder. It denotes that it's not accreta. In this MRI image, we can see the placenta covering the internal os. It's a placenta previa case. To prevent massive bleeding in patients with placenta previa or placenta accreta, we can place balloons in both common iliac artery or internal iliac artery just before the cesarean section, as in this diagram. So double femoral puncture was done. Balloons was placed in the internal iliac artery and deflated after insurance of their exit site. Patient was transferred to the operative room and cesarean section was done. The balloons was inflated just after delivery of the baby. And this meta-analysis that shows the significant effect of prophylactic internal iliac artery balloon occlusion in reducing the intraoperative blood loss and reducing the need for hysterectomy. And the fourth case, moving to my colleague Hend.
So, we have a young lady presented with coital pain, menstrual disorder, bladder irritability. Gynecological examination of the patient was done, revealing vulvar varices. Transabdominal ultrasound was done. Transabdominal ultrasound showing multiple refluxes, dilated parametrial vein with augmentation of the venous wave during Valsalva maneuver. So how to diagnose a case of pelvic varices or pelvic congestion syndrome using transvaginal ultrasound? As we can see here, here is the field of view of transvaginal ultrasound. We have the uterus, we have the right and the left ovary, we have the right and left ovarian vein, the right and left internal iliac vein, and we have the parametrial venous plexus. We have a criteria of diagnosis for pelvic congestion syndrome, starting with a gonadal vein trunk more than 6 mm, pelvic varices more than 5 mm, dilated arcuate vein crossing the uterine myometrium more than 5 mm, slow blood flow about 3 cm per second or reversed caudal flow, and finally a contralateral or ipsilateral swinging effect between the ovarian vein and the internal iliac vein. This is not specifically our topic, but we are going briefly to talk about the leak points that represent escape point that can actually reduce the venous hypertension of the pelvic region, transferring this overload to the varicose vein of the lower limb. We have 5 reported leak points in the literature, named the inguinal point, we have the obturator point, the clitoral point, the perineal point, and the gluteal point. So, in our cases, the embolic agent used either coils, which can be either pushable or detachable coil. Sclerosin material are used in the form of foam. The technique of foam preparation has been described in the literature many times. In our institute, we use the technique described by Lorenzo et al. The foam is typically created with 2 syringe and 3-way tab displaying a liquid to gas ratio of 1:4. It is advised that the foam should be created through 20 passes between the 2 syringes. Here we can see catheterization of the left renal vein, followed by superselective catheterization of the left ovarian vein, revealing dilated tortuous gliadal vein and pelvic varices. Also, a communication of the vulvar varices through the vulvar leg point impulization. The vulvar leg point is illustrated here. Impulization in this case was done using foam, and to the left we can see the control angiogram with non-contrast filling of the varices. So 2 weeks later, the patient was scheduled for both percutaneous and fluoroscopic valvoperineal varices impulization. So here we can see the ultrasound guided percutaneous injection, and here is the fluoroscopic guided technique, and finally the control image revealing non-contrast filling. This technique was invented in our unit by Dr. Karim Abdeldawab and published in 2022, and for anyone who is eager for more knowledge, you can honor us by visiting the paper. So eventually, other techniques used in women IR include the tubal coiling in hydrosalpinx. Interventional impulization has been applied in treatment of hydrosalpinx before IVF, which improves the result and decreases the risk of ectopic pregnancy. Also, we have either transrectal aspiration of pelvic collection, uterine artery impulization in adenomyosis, and mesotrexate injection, uterine artery impulization in case of retained placental product. So finally, to take home message, interventional radiology play a major role in women's health, which require a multidisciplinary team. Thank you.
ميرسي دكتورة هند ودكتورة أسماء، وبشكر كل جينيور ستافس بتوع الوحدة على المجهود اللي قايمين بيه، لولاهم ما كانش زمان الوحدة دي قدرت تستمر وقدرت إنها تقف لحد